Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, good evening. Let me first of all introduce myself. My name is Dr. Noura Al Qassimi. I'm the Vice President of Emirates Society of Ophthalmology, which is known as ESO, and also work as a consultant ophthalmologist at Sheikh Khalifa Medical City, Abu Dhabi, specialized in medical retina and uveitis. On behalf of Emirates Society of Ophthalmology, and in collaboration with AbbVie Immunology, we are welcoming you to attend our uveitis webinar with our eminent two speakers, who are, the first one is Professor Carlos Provizio, consultant ophthalmic surgeon at Moorfields Eye Hospital and Medical Retinal Service Director, London, UK. And he is also principal investigator for several clinical trials in uveitis. And the second speaker is my dear colleague, Professor Pier Giorgio Neri, who is a director of the uveitis service at Cleveland Clinic, Abu Dhabi. He is also a member in several international ophthalmology societies. Today, we are going through a journey to overview the latest updates with a brighter outlook in the management, mainly in non-infectious uveitis. So welcome. Discussions and questions will be answered at the end of the session. Mind you that the questions, you can put your questions in the Q&A box. If you have any specific question to a specific speaker, you can write his name, so I can direct the question to him accordingly. So our first speaker is Professor Carlos Provizio, who is going to talk about the local therapies for non-infectious uveitis. Professor Carlos, the mic is all yours. Is Professor Carlos around?
Okay.
Professor Carlos, can you hear me? Yes.
Yes, I can hear you now. Okay, apologies for this, but it was a technical glitch here. Okay. Can we start, Noura?
Sure, the mic is all yours, Prof.
Okay, thank you very much. Apologies for this, something technical here, but good evening to everyone, and thank you, Noura. Thank you for AbbVie for organizing this and for the invitation to take part. When I was asked to put this together, the idea was to cover some aspects of the management of uveitis, but I felt that it would be interesting to take you through a journey, which is a journey of what we do when we are faced with a patient uveitis presenting to us, because clearly before you treat someone, you have to reach a diagnosis, and you have some steps before you feel safe to make your final decision about the management. So I think the general goals for uveitis management would be you have to identify the source of the inflammation. So the diagnosis is really important. And the key in this diagnosis, as you see later on, will be to exclude an infection or exclude something that is imitating a uveitis. So we call the masquerades, most importantly, a neoplastic process. Your other objective is to control the inflammation, try to prevent recurrences and the cumulative damage which is a consequence of these several attacks of inflammation. With the final objective of all this is to preserve visual function and, of course, limit as well the development of any local or any systemic side effect. It's a real challenge to treat intraocular inflammation for anybody who has been working in this field. We know how difficult it is to reach a final diagnosis because the presentations are variable and we have to have a very good clinical experience and a sound judgment to be able to establish the best way of investigating and treating these patients. The limited options for management were a reality when I started practicing. This has changed, and many new alternatives have come up, and you'll be exposed to many of them in the course of this presentation today. We also know that uveitis is much more common than what we used to think, and also that it can be associated with significant visual loss in patients who are actually at a younger age. So the impact of that for society is a big one. We can see here, just as a very idea of the impact of visual and systemic health of global population, you can see 5–10% of visual impairment in the world related to uveitis. 35% suffer from significant visual loss, and some patients reach legal blindness. The incidence reaches levels of up to 200, meaning the incidence up to 252 per 100,000, but the prevalence is as high as 200 in 100,000 population. The age of the patients, as I spoke before, many times are younger individuals than your patient you worry about your macular degeneration. So those individuals where the visual loss will have a more significant impact in their long lives. And we figure out that many anatomic changes that are helpful in establishing this classification of the uveitis. This is from my colleague, Professor Karala from Tunisia, and it shows very clearly that you have these major groups in which we divide anterior disease, intermediate disease, or posterior disease, and if they're all combined, you have the pan-uveitis. So they're all important because the conditions affecting one of the segments are sometimes different from the ones that can be affecting the others, and also the decisions you make in terms of treatment choice will be influenced by these presentations. In terms of etiology, we can have the infectious etiology, which with 30 to 50% in developing world. If you go to places more developed countries, that number drops quite significantly, and you end up with the more non-infectious causes as the leading reason for these presentations. I'm just going to skip here now to the diagnosis. So how do you reach a diagnosis? So you have a patient in front of you with an inflammatory problem in the eye, and you have to establish the reason for that. So the first step is getting a good history. As in any area in medicine, understanding the history of that problem, how we get to that point is really important. And that is complemented by a very detailed examination of the patient. So it's important to understand how that condition is presenting, because many times the patient coming to you for the first time, that is when you have the best chance of understanding that presentation without the influence of other treatments, which happens many times in tertiary centers. The patients come to me for an opinion. They've already been seen by many different people with many different treatments. So I'm not looking at the disease as it should be when it first presented. So having a very good, clear history of that disease is very important. Does this patient have a previous ocular problem? What happened? Did they have surgery before? Did they have anything else that might be relevant? Trauma, for instance, is a very important part of this history that you take. Medical history is important. Family history is important as well. In terms of that present illness, so when we talk about characterizing that, it's important to decide if this is a single event or it's something that has happened before. Is this going on for a long time? What are the main symptoms at the time of presentation? How have the symptoms changed over time? What kind of treatment they have already been offered? And how they responded to that treatment they had before? And of course, if they have any systemic symptoms that might be relevant to the ocular presentation. So again, is this the eye affected when they had it before? Is always the same eye, or has it shifted between the eyes? How old were they when the disease started? So what kind of response, again, they had to treatment? Just repeating some of the concepts because they're really important. What happened in the previous strategy of treatment is quite relevant to what you will decide to do once you have the chance to assess this patient. I'm not going to spend a lot of time here, but just to give an idea that all this information can be of help. It doesn't mean that giving an exhaustive questionnaire of patients with every single detail is going to give you the answer, but it is a very important step in adding elements to your thinking process. this is just one example here of diseases in which you knowing more the behavior, location, geographic location, and places where they happen, it might help you establish a diagnosis, such as the case of onchocerciasis at the top and toxoplasmosis in some places where it's highly prevalent. So why do you test patients in uveitis? What is the reason why you test individuals? So it's usually you have to confirm or give support to a diagnosis. So that is, the diagnosis helps predict the natural history. So it's important to try to achieve that. Excluded diagnosis is not the most important reason why you do it, because you're really trying to confirm your idea. But sometimes it's important to make sure that you're excluding what I said right at the beginning, an infection or a masquerade. And of course, it can be helpful in establishing a baseline, which will, in terms of a therapy that you may be introducing. So really don't forget one important thing. You have to do a complete examination of the eye. So looking at the front of the eye, but dilating the pupil and looking at the back of the eye. Because many times an inflammatory event affecting the front of the eye is just the tip of the iceberg, which will really be more obvious when you dilate and you can identify the real source of the problem. There are situations in which I find that tests are not really necessary. So if someone presents with a very mild anterior uveitis for the first time, it's not a granulomatous disease, it's not associated with systemic symptoms, it may very well be a one-off event. And in those patients, I tend just to treat them after my history confirmed this is nothing else to worry about, and then observe how they respond and decide if I need to do more in case they recur, especially if they recur in a short time. Keep in mind that a recurrence may, in this case, not be a true recurrence. Maybe just your treatment is going down and you have escape of control of the first event rather than a new event, which is really important to separate. If you know the diagnosis is there is a systemic syndrome compatible with the diagnosis. So the patient comes to you saying, I have this disease. For instance, I have sarcoidosis, and you see the findings in the eye are compatible with sarcoidosis. Or I have Behçet's disease, and the findings in the eye are compatible. You don't need to go any further, because likelihood is that what you're seeing is part of that systemic diagnosis. In terms of classic presentation, so if you look at someone presenting with a condition that they are obviously the phenotype gives you the answer, so you don't need to be investigating this further. Someone presenting with this kind of picture is likely to have a herpetic uveitis, so you don't have to be exhaustively requesting blood tests. The same applies for someone presenting with a satellite recurrence adjacent to a scar, that is clinically toxoplasmosis. So in some situations, there's no point in requesting tests just for the sake of requesting tests. You know what the diagnosis is, and you can act on it without having to do more. So when do you test? You test anything beyond what I just said to you now. So disease that is recurrent, severe, bilateral, simultaneously, chronic, granulomatous. And of course, if patients are having a treatment because you think it's something you know, but they're not responding to that treatment, then it means that you have to investigate further to understand why this is happening to them. And how do you test? Well, I've already told you about the history, about the examination of the patient, because those elements are going to give you the findings or the signs and the symptoms that will together build in your head a differential diagnosis. And that is when you go for this picture here. So this is the picture in which many people get trapped and out of desperation tick all the boxes in the blood form, because they're hoping that they will be helped by this collection of tests in reaching the diagnosis. And essentially, many times, this is exactly the opposite. What you find that these results are going to generate more confusion, because you may find a result which doesn't fit the clinical presentation, and then you have to explain why that is present and what is the meaning of that finding. So do not tick boxes for no good reason. You're ticking boxes because you think that they're going to be helpful in establishing the diagnosis for you. So the sound clinical judgment is really important. It is putting together the elements of your examination which will help you make the diagnosis. So it's uveitis with skin lesions, it's uveitis with ischemia, it's uveitis with hypopyon. So all the things, putting them together will help you guide which way your thinking process is going to go. When do you stop testing? So if the diagnosis is known, so you don't have to go further. Once the most important infections or neoplastic processes are excluded, then you don't have to be further, because you cannot just testing patients for non-infectious or non-neoplastic processes. We don't have tests at the moment which are very helpful in pointing out conditions which are clinically defined. So it's not infectious disease. You know clinically how it presents, and you should be able to make the diagnosis on the clinical presentation of that patient. Requesting an HLA B51 is not going to be very helpful in achieving your diagnosis. When do you retest? So you have reached your diagnosis, you think you're correct, you have tested and you reached your conclusions, and you think you have the diagnosis, and you start treating the patient, but you realize that in the course of that, there's a change in the disease pattern. So in that case, you may have to go back and retest. Usually, your diagnosis, if something is wrong, is because you got the wrong diagnosis, or because you are using insufficient treatment, you are on the right track but not giving enough, or because the patients are not using the treatment which you're doing. So one of the options is that you are wrong, and so you may have to retest to be able to achieve your diagnosis. The other situation is when the tests are showing that they're contradicting your sound clinical judgment. In terms of how do you treat the eye, getting medications into the eye is not always very easy. There are several natural barriers which are there to protect the eye, and also they represent a barrier for the penetration of drugs into the eye. Once these barriers are intact, they are really going to limit the use of the presence of drugs into the eye. So what are the treatments that we have for the non-infectious? So I'm not going to focus on infectious uveitis here, because they are a completely separate talk. They all have their peculiarities of how we treat them. So it's going to be outside the scope of this talk. But I just want to give you a flavor of the strategy that you can use in the management of a non-infectious posterior uveitis, considering intermediate and posterior as one group here. For topical, is mainly for the anterior uveitis. So we know that they're very effective in treating disease at the front of the eye, but the drops that we normally use don't seem to penetrate very well to the back of the eye. I know that I don't have access to difluprednate, which is Durezol, which my American colleagues do, and they claim that yes, Durezol is powerful enough to have an effect towards the back of the eye. Periocular injections have not been used very widely, even though they were our very first attempt to increase the concentration of drugs inside the eye by a local route of therapy. And then, of course, we had the use of intravitreal approach, which goes with injections or devices. So both of these approaches are a way of putting medication into the eye at a higher concentration. The systemic therapy is going to be the step which Pier Giorgio Neri will be covering in a while, but it will involve a possible range of options, including the oral steroids, which tend to be our first line, but then this has evolved with many other alternatives, and I'm not going to dwell very much into this because of his presentation in a while. So we have to be, when we are treating patients, we need to be very careful about understanding the effect of their health in general. So any other factors that might be an impact in the outcome in terms of the treatment that you're using may complicate some other problems they have. What is the potential for recovery? So you want to be treating patients and doing the best you can in situations when you know that there is potential for recovery. So there are many factors that we have to take into account that are clinical factors that will be very relevant to our decisions in terms of which way we're going to decide to treat our patients. The strategy, so we again have the establishing the diagnosis as a very important step. We evaluate the visual function to make sure this patient still has very useful visual function and that we have work to do to make it better. We check the general health of the patient, and then we will be able to carry on monitoring this patient very closely. So this stepwise approach would go from things that we're used to do, the periocular treatment, and going into the intraocular therapy with intravitreal injections or devices, and then you can go systemic. The issue is this is not necessarily a stepwise approach. Your decisions will depend on the disease that you're faced with. Some diseases will go straight into systemic therapy because there's no role for local therapy in their cases. Like Behçet's disease, you may use an injection just as a very acute way of treating an aggressive event, but the control of this disease will depend on systemic therapy. The same apply to other conditions like VKH or sympathetic ophthalmia, when the use of local therapy is really not the way forward. So this decision about which way to go depends on the diagnosis you make, on the presentation you see, but many times you escalate from only local to systemic, but this is not necessarily an obligatory sequence of events. The intravitreal steroids, I think we've all been through the use of this approach, and essentially they do allow you to bypass all the barriers, get high concentration in the eye. They do involve a procedure with an injection that has to be repeated because the effect is limited, so there is a disadvantage of having to be repeating. So the steroids as injections were the first thing we used, and there was a tsunami of Kenalog injections to treat patients with inflammation some time ago. What we've seen after that is that devices were introduced because there was a way of trying to reach a better long-term use of this treatment rather than having to inject these patients so frequently. So this is what we did initially with Kenalog, which is a totally off-license indication, then replaced by Triessence, which was a sterile, preservative-free formulation. And then, of course, we went to the drug delivery after that, as I mentioned before. So the first developed was the Bausch + Lomb Retisert, which required an operation to insert it via the pars plana and released fluocinolone acetonide over a 3-year period. What we can see here that it had a huge impact on the protection of the eye in terms of time to recurrence, really controlling much better the inflammation than the patients receiving systemic therapy. These treatments didn't come free of problems, so safety-wise, they were associated with significant problems in terms of intraocular pressure and a rise in the need for filtering procedures. And they were associated nearly to all patients with development of cataract. Ozurdex came as a dexamethasone, a biodegradable device, which has been licensed for the use in many different indications in the eye, including uveitis, and it was based on the Huron study that showed that there was a significant impact in terms of vitreous haze and also improvement in best-corrected visual acuity. So this device proved to be very useful and is still very widely used, but has also a limitation of the duration of the effect, which is not very dissimilar to an intravitreal injection of depot steroid. Fluocinolone acetonide, which is known as UTIC in the US and Iluvien in Europe, also is a fluocinolone implant similar to the Retisert, also delivering the drug over 3 years, but a much lower concentration of the drug, also leading to a significant reduction in the occurrence of recurrences of the disease. The issue of recurrences also is important to stress that if you look here at the recurrence over 36 months, you can see that the patients had a very good response. So the patients receiving the implant managed to control the disease. At least 34% of the patients never had a recurrence. And if they had a recurrence, most patients had only one recurrence. So it did provide a significant control of the disease in comparison to the patients receiving standard of care. In terms of safety, which is very important because of the concerns we have with steroids, it showed here as well that you didn't have too many concerns. It was essentially a situation when the pressure wasn't really misbehaving as it did with the Retisert, and we're achieving good levels of pressure with the need of intervention being very limited. Just to briefly mention the anti-VEGF drugs because they may be useful in the treatment of patients with macular edema, which is considered more chronic, and there are some good evidence that they may be beneficial, but again, you fall into the situation of having to repeat the procedure on a regular basis. And keeping in mind that without controlling the inflammation with the other methods we discussed, this alternative is not going to be very useful. This is my final slide, which stresses here the limitations of the local therapies. It shows that the duration of the effect may be limited, they have to be repeated, and they can be associated with complications. They are more problematic in bilateral disease, even though not exclusive, but create a problem sometimes. They can be associated with problems with intraocular pressure when steroids are used. Some patients are needle phobic, and that is a real complication because patients need to be sedated. And of course, if the patients have an active systemic disease, or if they have choroidal inflammation, then it will be not a good strategy, which I'll show you later on when I'm presenting one of my cases. So I think I'm going to hand over now to Noura to introduce Professor Neri. Thank you, Noura.
Thank you so much, Professor Provicio, for this excellent overview regarding local therapies. Now we are going to Professor Neri, who's going to talk in two consecutive topics. The first one will be highlighting the systemic therapies for non-infectious uveitis, poetry in motion, and the second one would be theory into practice. So, Professor Neri, welcome.
Thank you very much for the invitation. It's an exciting, initiative. Since I always love, to have conferences, but I never went broadcasting, and I think this is a great opportunity for all of us, to challenge ourselves and go for this new experience. So, why I've chosen poetry in motion? Since, I think that's, this definition, poetry in motion, is just a way of a different way for interpreting the reality. And when you look at uveitis, you may get the point that uveitis is one of the most challenging entities in ophthalmology, and this is for real something that can threaten the vision of our patients. And when we look at some charts, we can see that it's just falling exactly right in the center of the ages, so where a person is productive. So that is the major concern that we may have. So uveitis is affecting people, as Carlos mentioned before, in different ways. This might be anterior, intermediate, posterior, panuveitis, whatever it is. But the most important thing is that it's affecting people that can be productive during the age in between 16 and 70 years. So when we consider the risks in patients for affected by uveitis, you can see that ocular complications are occurring mainly in patients with non-infectious uveitis. This is due to several factors, but the matter of fact is that it is not only a matter of the statistically significance of that, but it's the fact that uveitis is a sort of, just a boat that is driving you to the hell, and very often you have to pull off, the people that is affected by that. But why it is like that? I want to present, just two things. Have you ever, asked yourself why a PKP is more prone to have, a corneal graft rejection compared to a doc? The reason is just because if you look at the medical literature, you may see that this gentleman here, that was Sir Peter Medawar, who passed away in the 80s. He discovered that there was the so-called ACAD. ACAD means anterior chamber associated immune deviation. It's an acronym which is very well known by the scientific community. And this is, what he observed first. That is an obvious uveal melanoma and is affecting the iris body. And you may see clearly that, the growth of that was very prominent. When you look at this, you can have the feeling that, something is absolutely, weird in anterior chamber. But the most important thing there is that he saw that the growth of that tumor was much faster than any other tissue in the eye. And the reason was that the control by the immune system there was absolutely not capable to keep under control the cancer there in that site. So let's say that I love always to mention what Wayne Strading, that was probably one of the greatest or even the greatest immune pharmacologist in the history, that released this beautiful lecture that was called the Ocular Immune Privilege and the Faustian Dilemma. Faust was a character of a drama where he made a sort of deal with the devil, and he said, let me have a very wealthy life, and then you can take my soul afterwards. So uveitis is more or less that. When you got this deal which is disrupted, you may have something that can occur dramatically in the eye. So let's say that the ocular immunology is more or less like this. It's like a castle made by cards. So you see that there's a lot of fragility in that, and whenever you got an issue that can occur, in the anterior chamber, posterior chamber, or in the posterior pole, or maybe in the intermediate uvea, you can have something driving you towards the hell, as I said. So let's say the most important thing is that, we have to distinguish two different entities. One is the so-called non-infectious uveitis, which is just confined to the eye, and the other one is associated with systemic diseases. But let's say that, the term uveitis doesn't mean anything, per se, but it's just an umbrella term, which is telling that there's a series of different, entities like these puppies that, have the same name as an umbrella one, but they are presenting different type of severities. When we go through this, we can see for systemic disease, we can have spondyloarthropathies, which are associated with uveitis, inflammatory bowel disease, juvenile idiopathic arthritis, Behçet, focal aggravata, sarcoidosis. We can go through all of them. But the most important thing is the fact that whenever you got something like this, you can see that different types of uveitis are associated with different types of clinical entities. So when we go through this, as I said, we can have anterior, posterior, intermediate, and posterior uveitis. And of course, we need to distinguish between, the granulomatous and non-granulomatous ones, but that was addressed by Carlos, and I won't go through this. The most important thing, and this is very important and crucial in order to make the right decision, it's to distinguish between the infectious and non-infectious. And disease, particularly important for the systemic disease, for the systemic approach, since you're going to give something which can affect the system. And if you get wrong, of course, you can have the whole system which can be involved in your choice. There's one thing that is assumed as, a cornerstone for uveitis, and is that disease, a T cell-driven cellular immune response. So when you look at this is very similar to different type of diseases, and you can even see that there are similarities between, different relatives for the immune phenotype of the disease, and these are called the multiplex family. It means that you can have someone which is affected by uveitis, another relative can be affected by inflammatory bowel disease. So you can have, sort of mix up of things depending on the genes which are switching on or switching off for what is occurring in the eye. What we're seeing is that, the disease, as I said, is a T cell driven, but there are two specific entities which are the ones which are representing the main players of this game, and are the CD40 helper 1 and 17 cells. And as you may see, we can have also the involvement of other bodies in the eye structure, like the vitreous, which can be severely affected. And of course, this can drive towards the delivery of a series of cytokines that can create a cascade, creating the conditions of this vicious circle. Genetic is important. This is a publication that I made with my colleague, Dr. Piki, which is working with me. And you may see that the HLA are strongly associated with several diseases, like the one that is associated with birdshot. And we, thanks to our colleague and friend, Carl Herbert, we have worked together with Carlos, which is one of the authors of this beautiful publication, is that we found that 100% of patients which are HLA-A29 can develop the disease. But it is not to the contrary. So it means that if you are HLA-29 positive, it doesn't mean that you have, to have the disease later on. So the most important thing, whenever you see a pattern of a disease which can resemble birdshot and you test for HLA-29, this can be the hallmark of the disease. But of course, there are others like Behçet. This is just to mention one that can affect several organs. But the most important thing is that the worst involvement and the most frequent one is represented by the eye involvement, and it's very represented, here in the Middle East. So just to summarize, we can see that we can trigger the activation of T cells in many ways. We can have the antigen presentation. We can have the damage per se. Let's say that if you have a damage in one eye and you got the sympathetic of thumb in the contralateral, you're just triggering what is just a mechanical damage. And then you can have the infection. Then you have the activation of cells, and then this can lead to the pro-inflammatory proteins transcription, the T and B cells activation, and then there's also the response to stress. So you may see this picture. I'm not go through this because it's too complicated, but can, let you understand how complicated uveitis might be. And you got plenty of publications showing on how the immune system can interact with the eye and is interacting in the eye, not only locally, but also systemically. So let's say that there's even a big question. Is it, uveitis an autoimmune or autoinflammatory disease? So the difference is just a, sort of balance between what can happen, in the structure of the eye. You can have the activation of autoinflammation or the autoimmunity. Let's go through this and understand better, because we don't know whether it was born before, the chicken or the egg. So let's say that autoinflammation is something activated by the inflammasome. And inflammasome is driven by a triggering that can be provided by several different entities, including prions, bacteria, or viruses as well. So when you see that there's the activation of inflammasome, of course you can have the activation of pro-caspase 1, which is activated to caspase 1, and then you can have the cleavage of a pro-interleukin 1 beta and the pro-interleukin 18, and then you can have the activation of the immune system. But then, as you may see there at the bottom of the slide, you can see that there's also the TNF-alpha, which is participating in the activation of the autoinflammation, but is a player also for the autoimmunity. So the most important thing is to understand that right in the center of that vicious circle, you may have, and you have to consider, that a crucial role is played by TNF-alpha. So considering this, we got, anterior uveitis, and let's say that acute anterior uveitis represent probably the majority of, the whole amount of uveitis we have to face in the daily practice. But the ones which are giving us our times are all the others, and it's not acute anterior uveitis, since it is a very local treatment. And I'm glad that Carlos is here because, he can be the witness of my philosophy that as per what I learned from Professor Forrester, that was my mentor and friend in Aberdeen, uveitis is not a local disease, but it's a systemic disease. So let's say that the goals are just to reduce the symptoms, to control the inflammation, to prevent visual function from worsening, and also to prevent or limit the complications, which are the ones giving us our times. So let's say that if we merge all together and we create a sort of graph like this, and if we want to control every single component, we should have a wide area. But when the width is like this is a catastrophe, and we don't want to have that. So how can you do this? You listen to Carlos, and Carlos told you about the local treatments, but when you have a very severe disease, particularly when you have a bilateral one, you need to go through this flowchart. I don't want to show you, the different guidelines. This is very easy. So generally, you try to approach with corticosteroids, and then when there's a treatment failure, you can increase the corticosteroids, and then you go through the systemic immunomodulators, and when you fail that time, you can think about biologics. But my question is that always true? I don't think so. And I'll tell you what. Number one, we know the steroids. I don't want to go through this, but I want to give you, just some advices. You know that they are potent, fast-acting. They're great. You can use, them in different ways. You can create, the immune suppression by using 1 milligram per kilo, or maybe you can use the suboptimal doses, which can, drive towards the control of inflammation without immunosuppressing the patient. But when you look at this, you may see that if you lose for a long time steroids, you can have several problems, including Cushingoid syndrome, which can be driven by your treatment, and that's super important. So let's say that steroids are welcome, but we don't want them to stay in the house for longer. So we have to think something, and we have the steroid-sparing drugs. What are the steroid-sparing drugs? Steroid-sparing drugs is a series, I would say, of different drugs which may be used, and they can keep on the control of uveitis, not without steroids. So you need to use the steroids. You have no other option. You need to start with steroids and then to combine them. Of course, you need just to taper the steroids until you stop them, ideally, and then you can go on with the steroidal with the steroid-sparing drugs. But of course, there's one thing which is very important, is the fact that we analyzed this in this publication that came up, a few years ago. And when you look at the method, was very rigorous. And when you look at the different drugs that might be used, you can see that the level of it is quite good for most of them, but of course they are not the optimal ones. Because when you may see this, the rate of control of uveitis for mycophenolate, the success is at a year, 73% roughly. Cyclosporin is 52, so it's just to throw a coin and see whether you get the phase A or phase B. And then the methotrexate as well is roughly around the 70%, and azathioprine is a little bit less. But all of them present, the possibility to be combined together. But the more you combine, the more you can have side effects. But anyway, let's say that the common side effects are pretty present in the treatment with the steroid-sparing drugs, even though the only advantage that they have is that since roughly all of them lost their royalties, they are not that expensive. But let's go through this. The treatment options are steroids. I just would like to ask all of you, do you know that steroids are off-label? So there's no label stating that we can use them in uveitis. The systemic ones are not allowed, but you're using on the daily practice because it's just something that you did many times. Cyclosporin, we're using the suboptimal dosage. Since, if you go through the medical literature, the registration trial that was driven by Chi-Chao Chan and Professor Bob Nassenblatt, who passed away a few years ago, you may see that the dose that has been suggested was 10 milligrams per kilo. And I can challenge you that if you give 10 milligrams per kilo for every single patient, you get a renal impairment for every single patient. Then you may have tacrolimus, and tacrolimus is off-label, as well as sirolimus, methotrexate, azathioprine, mycophenolate mofetil, and cyclophosphamide. So let's say that we have many options, but nowadays we have to change our mind. Because when you don't have the response, which is optimal, you can get desperate. And I don't want to be desperate. So what happened? I would say that science is so exciting. It's a great thing because, you can see that there was a progression. And monoclonal antibodies are the very last resource, weapon, or whatever you want to call that we can use for the treatment of uveitis. And we can go from MOMAB that were completely murine to the MUMAB, which are completely humanized/human. So the most important thing is that the very first one that was used, and I was blessed to use that, with Professor Forster the first time, had a wow effect. Because Campeth 1H was used for severe non-responsive uveitis, and as you may see, this was acting to be T cells, B cells, and natural killers. So it's too effective, I would say, and now it's being retired from the market just because it has too many side effects. And this was like an atom bomb, and we don't want to have atom bomb. We want to have homing missiles. So when we go through the medical literature, we may see that there are several attempts, for several different drugs, but the ones who are the most important are only the monoclonal antibodies and TNF-alpha. And adalimumab is the only one that has a level of evidence of A. So when we go through this, we see that still in the pathophysiology, TNF-alpha has a central role. And when we go, through the literature, we see also other models. We can see that this is directly proportional to the activation of T cells, which makes sense to me because the more you got TNF-alpha, the more fuel is available for our cells, so we can have the activation of the system. But the animal model is telling something important. When you have knockout mice for the TNF-alpha receptor, you can have lack of staining of macrophages, which are the real, ones threatening the structure of the retina. So let's say that we had the chance to use, drugs like the chimeric ones, that was infliximab, but nowadays we can use two different drugs, which are the ones fully human, which are created by new technologies, which can be either phage display technology or DNA recombinant. So, but when we go through the literature, you can see, there were plenty of publications for infliximab. And of course, forget about the fusion protein because, this has been proven to create uveitis to court, so has not to be used in uveitis. But when you look at infliximab, it seems to be great, what we have, but of course, the quantity of publication is not associated with a registration trial, and there's no chance to get this drug back in uveitis again. So let's say that the most relevant quantity of literature is just dedicated to anti-TNF-alpha agents, and particularly to adalimumab that has an level of evidence of 1 B, which means that it's just below a meta-analysis. So that is amazing. And you can see that the level of recommendation is A, since there's a very strong, evidence that this drug can be used for that. So I was a fan since I started treating uveitis of adalimumab, because when I came back from Aberdeen, I was a fellow there. Everyone was using infliximab, and I decided to use adalimumab because it was user-friendly. At that time, was not off-label, was hyper off-label. And I used, in these two cases first, where I saw that there were two kids that were desperate. You can go through, the publication if you wish. But, I think that images are very, 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 I would say, clear to you. You may see that particularly on your right side, you see a huge massive edema that was not responder to local treatments, as well as the combination of mycophenolates and cyclosporine A and steroids. And I remember that this kid that was 7 years old, after adalimumab, and I didn't use steroids at all at that time, had a massive and wonderful result after using that. And that is even more evident. Same thing, teenager that was treated like this. These are the very two pediatric cases that treated with adalimumab and published in a journal of rheumatology. So this is an overlapping syndrome. You see that in the signing green angiography is showing, multiple dots, particularly in the picture on your right side, which is the left eye. But you may see that afterwards you got the attenuation of that, and the affection that was impairing the sight of this gentleman got much better. But these are off-label treatments. But when we go through what has been done, because at that time we're off-label, we see that the only phase 3 trial that has proven to be effective for uveitis has been published yet, but we're registered to trials.com. So let's go through this. It's amazing what happened, meanwhile, since Huangdong Yang, with all the other researchers, published this in The Lancet in 2016, as well as Glenn Jaffe, did the same for non-infectious uveitis, which were active in New England Journal of Medicine. I would love to be part of that, but I was not. But anyway, that's the matter of science. So we got the evidence that they are working. Let's go through these two, Visual 1 and Visual 2 trial, that were the registration trials. So Visual 1 and Visual 2 are very similar when you look at, the concept of these trials, since they started to use a very minimum amount of corticosteroids in order to be ethical by using an arm that was placebo-controlled but had a medication. So when you look at this, you may see that it's beautiful to see how the survival curve is so superior to the control group. And I can tell you that the rigidity of the criteria applied to these two cohorts was so crazy that I thought that it was impossible to accomplish the primary outcome measures, but they did it. So it means that the drug is super effective in controlling uveitis, as well as it's very safe. But I was not surprised like that, because this was just the 14th indication in a drug that has more than 10 years of history. So looking at this, I think that this publication tell what? Just because it was the merging of the two trials in a real-life model. And when you look at this, you see that the cohort was massive. You got 424 patients. But the most important thing that if you go through one by one, every single column of this graph, you may see by comparing with the other previous trials that the results for this trial was better than the ones that were used for the randomized controlled ones. And this is true for every single component, including the grading of cells, as well as the vitreous haze. But the logMAR visual acuity is very important. What we want to have is having a patient with a stable visual acuity and rescue that. And this is some important stuff. So I would say that the stability of visual acuity, as well as the reduction for the use of steroids, till we got the amount of drug, which is very minimal, that is the real goal that I wish to have. So the conclusions for the focus group is that the only one that has a level of evidence which is strong enough to say it's A is only adalimumab, because of the background and everything that can be done. But this publication is even more astonishing. This is SYCAMORE Trial, published by my friend Andrew Dick in New England Journal of Medicine. and I don't want to go through this. This is for pediatric uveitis. The concept was very well designed, and I can tell you that it was very ethical and involved. The ethics committee, of course, that was controlling everything. And I can tell you that for the first time ever, that trial was interrupted before they reached the goal because it was too good and was not necessary to go on with the trial. So the drug is approved for juvenile idiopathic associated uveitis as well. So let's say that this is amazing, but this is just a contribution that we are just going through now, and we want to publish. This is a triple combo therapy that was not effective. So it means that there were 3 drugs plus the local steroids that were not effective for controlling cystoid macular edema and uveitis. And you may see that the curve is is going down, dropping down, and you may see that the difference in between the different time frames is absolutely statistically significant. Maybe the question is, did they have any kind of recurrence? Of course, but the goal is not to have any recurrence, but to minimize the possible risk to have a very severe one. I want to target another point, because we were talking about the TNF-alpha. What about interleukin-1? There's several groups, and particularly there's a group in Italy which is pushing a lot, the treatment for the anti-interleukin-1. When you look at this cohort, you can see there is only one paper that is including more than 50 cases. And you can see that all the different data are quite confusing because, are 2 drugs merging together with different dosages. And I think this is not really ethical if we want to go through and make conclusion telling that something has to be done. And of course, we need also to tackle the problem about what means a sustained response. It means that it's a long-term one. And I think that, when you look at the data there through the medical literature, you can see that this is not true. So I would say that I got confused reading that. And I kindly ask you to go through the publication that don't believe them without being a little bit critical for that. So let's say that there's another issue, also the cost, because, canakinumab, which is one of the twos, is roughly around, $174,000 minimum to a maximum of $347,000 per year per patient. So before we say you can go for that, you need to have an evidence which is strong enough to allow you to tell that. What about the others? Anti-interleukin 17, which is a breakthrough for many other disciplines like dermatology. So let's say that secukinumab was not that satisfying, and gavokizumab as well, because both the registration trials failed and they are not available at all for the treatment of uveitis. So this is a big question mark. But of course, the challenge Behçet disease, which is the worst one. So it's like to play a game as a first one versus Real Madrid. So I want just to bring this case. Look at the face of this guy. Came to my practice, 17 years old. He had 5 years history of bilateral severe uveitis, cataract surgery, vitrectomy, severe bilateral visual impairment, steroids, azathioprine, cyclosporine when he came, steroids more than 20. Look at the face. You see that he was desperate. And the first thing that he said, this is not life, doctor. So he was even thinking to suicide. I don't know whether this was, something that occurred just because the guy, got depressed because of the huge amount of steroids that can drive towards this condition or not. But after I took the decision, and I was desperate as well because I didn't know what to do, I gave him the drug. I tell you that, oops, I think I went too forward. You can get the, where's that? I lost my presentation, guys. You can see that there's one slide missing. Yeah, there's one slide missing. So let's say, I'm sorry, guys. I don't know where the slide is, but you might have seen that the face of this guy was very healthy and this guy didn't have any problem at all. So let's say that the take-home message, I'm sorry that I couldn't show you the picture of this guy, but I'm still in contact with him. He's still in Italy. And I can tell you that I'm delighted that this key gave him a new perspective. And this is the meaning of improving the quality of life of people. That is the end of my first presentation, Noura. Should I go on with that for the next one?
Sure. Yes.
So the second one, thank you very much. Thank you. So the second one is a presentation which is based on 2 cases. very easy. I don't want to preach you. I want to just tell you what the Pandora's box is. I mean, for those who loves mythology, Pandora was a girl that had a box. And in that box, there was everything. So when you have someone which is telling you, do not open the Pandora's box, means that any source of great and unexpected troubles can occur. So let's say that when we try to open the Pandora's box, we can have a lot of issues. So let's present the first case. So let's say this patient came as a casualty for sudden vision loss with apparently no further symptoms and quite good health, apparently. So the first physician the patient, just reported that this patient was 32 years old, male. The best corrected visual acuity in the right eye was absolutely unremarkable, 20/20, and the left one was 2400, so quite impaired. Intraocular pressure normal, no flare on cells in the tear chamber, but he presented with this picture. So when you look at the right eye, roughly seems to be normal, even though I can argue that is normal or not, because I'm not convinced that it's very normal. But looking at the left, the sudden reduction was, put us big question mark like central retinal vein occlusion. When you look at this, I don't believe so. Since you have to look at the distribution of the hemorrhages, you can see that there are some ghost vessels down there, particularly in the infratemporal branch. And you may see that some vessels are just, typically as defined as a sheathing of vessels. So you have, sort of a white coat, which is just, following the course of the vessel. When you look at this, you can ask yourself, why this does not look like CRVO? So the first might be a pattern of hemorrhages, might be the distribution of hemorrhages, might be, both together or none of the above. So when you look at this, you can see that the reason for that is that answer 1 and 2 are the ones giving you the answer for that. Because when you look at the picture, as I said, you see the ghost vessels and you see the distribution also of the different hemorrhages. So fluorescent angiography is giving us the answer. You may see the left eye is pretty obvious. You see a severe retinal vasculitis. I would add severe occlusive retinal vasculitis. And then when you look on your right side, you see a blood retinal barrier impairment, which is pretty obvious as well. So this is the typical occurrence of Behçet disease. So we have decided to pause the patient, and we decided to give the triple immunosuppressive agents like it is recommended for severe cases by EULAR. So we used azathioprine, 2.5 milligrams per kilo, cyclosporine 8, 3 milligrams per kilo, and prednisone, 1 milligram per kilo. So let's say that the response was not bad. So there was an improvement. But afterwards, while we were tapering, we had the occurrence of the affection of the right eye. So the right eye had a recurrence of a very bad occlusive retinal vasculitis. And we don't want to have that. So the only thing that was missed, or at least the next step, so the upgrade of the treatment was to treat the patient with a monoclonal antibody. And since we had the chance to treat the patient with adalimumab, we have treated as per protocol with 80 milligrams sub-Q, followed after 1 week by 40 milligrams per subcutaneously, and then by 40 milligrams every other week. So at the end of the day, this is after the treatment. And then you may see that here on your left side, the occlusive retinal vasculitis is practically solved, even though there are these wide ischemic areas. And then there's also the right eye with a blood retinal barrier that came back to normality after 3 months. The only step at this stage that I would do is to consider what to do. So stop Humira and observe, keep on Humira, laser photocoagulation of the ischemic areas, or keep on Humira and laser photocoagulation. The correct answer at this stage is just we need to use both the techniques. The one thing that I want to stress is that we do know on when to start the monoclonal antibody, but of course we don't know on when we have to stop it. There's a lot of speculation, but no one can tell you exactly what to do. But there's one thing which is clear, that we need to laser these areas and we need to use this technique. I didn't take, the picture afterwards because I want you to keep in mind, the technique. Don't laser the whole retina, just laser the retina which is affected. So I would say that you should use the fluorescein angiography as a navigator for that, and this is a good idea. So let's go on with the second case, and we're gonna end up very briefly. So this is a case of a unilateral pain in the left eye, 54-year-old male. The best corrected visual acuity is 2400. The intraocular pressure is quite low, is 8. And the anterior chamber has a flare of +2 and cells +1. When you look at the pictures, you may see that the indocyanine green angiography is telling you a lot. So if you ask yourself what it might be, this might be multifocal choroidal or a stromal multifocal choroiditis, or a serpiginous choroiditis, or all the above. Of course, it's neither a serpiginous choroiditis as per pattern, because this is not the case. And it is not a stromal multifocal, it is not a multifocal choroidal, but it is a stromal multifocal choroiditis, because you can appreciate the black dots since the beginning, which means that the granulomata are right in the center of the stroma, and this is multifocal. So Herbert is strongly supporting this classification, and I believe that this is a correct one. So when you look at that, you may understand why, because this guy had a lost contralateral eye, and the diagnosis is pretty easy, because he had a 6 operation in the right eye for a trauma, and this is pretty obvious, it's a sympathetic ophthalmia. So when you got sympathetic ophthalmia, you need to argue, whether you have to go for subtenon or steroids and traditional immunosuppressants. This might be reasonable, or subcutaneous adalimumab. I would say that we decided for the third, and we have treated the patient, and you may see before and after the treatment. So let's say that the take-home pearl at this stage is that when you look at disease after 24 months, you can have a long-term result, and this is the most important thing. So just stressing the fact that you need to consider the severity, you have to consider the type of systemic therapy, you need to consider the combo treatment, so you may even combine sometimes different drugs. Remember, when you got the disease, which is severe enough, don't waste your time, go for biologics. And the answer is adalimumab, as per efficacy and as per registration trials, and since it is allowed for severe cases of uveitis. Thank you very much.
Thank you so much, Professor Neri, for your wonderful presentation. And there are a couple of questions will be answered after Professor Carlos' presentation. I urge you, audience, to type your questions in the Q&A box so we can have the maximum benefit from our both excellent speakers. Professor Carlos,
yes.
He's going to talk about the theory into practice. Can you hear us, Professor Provizio?
Yes, I can hear you. Can you hear me?
Okay. Yes.
Very
clearly.
well. Very well.
Okay.
Thank you. So I'm just going to present two small points here. One is a bit of data from our experience in London with the use of adalimumab. And the idea of telling about failures is because you always worry about starting a new treatment and wanting to establish how useful it is. So we were looking at that, and essentially, you know very well, Pier Giorgio has already very clearly described to you what adalimumab is all about, the trial results, and the fact that it is very well, the evidence is very strong for the use of this approach. In the UK, we had the license and the approval by NICE coming in 2017, and since then, of course, we have been using Humira more frequently. So we wanted to assess over the period of time following that how well our patients were performing. And what I want to show you here is very simple. This is the uptake at Moorfields, just to show you the numbers went up quite rapidly. The data is not up to now, but it's just showing you a flavor of the behavior, and that curve continued to go up following that date. And essentially what we had here, total number of patients were 130. We had failures of 12 patients, Moorfields 9, at St. Thomas's Hospital 3. What we wanted to establish here is characteristics. So these are the diagnoses of all the patients that we prescribed Humira for. And you can see here a large number of patients were idiopathic, but interestingly, in our hands, we have a large number of birdshot patients. So many of them went on to receive adalimumab. And you know that I'll show you in the next case how important this is for this specific group of patients. We have here the dose that they were using. So most patients were using the standard regime of 40 milligrams every 2 weeks following that initial loading dose. But there were a few patients on an unlicensed regime, only one patient actually receiving it on a weekly basis. The causes of failure were patients showing a lack of response, which are only 7 of patients, and there were nearly half of them also having problems with side effects. Let me just advance here. These are the causes of failure. This is the side effects effectively here, showing that we had one patient with a hemorrhage, which is described as a common GI disorder. Neutropenia, also considered a very common blood disorder. Psoriasis, a common skin disorder. Mood alterations, common psychiatric disorders, and the myelination, rare nervous system disorder. So these were the main reasons why these patients had issues with the medication, forcing them to discontinue their therapy. This is the recommendation from NICE in terms of criteria for defining failure. So they consider a failure instead to tell you to stop the use of that intervention if the patient had a new active inflammatory lesion, chororetinal or inflammatory retinal vascular lesion, or both, or 2-step increase in vitreous haze or anterior chamber cell grade, or worsening of the best corrected visual acuity by 3 or more lines or 15 letters. In terms of what we have in terms of the duration of treatment prior to failure, so I'm just going to highlight very quickly here. I'm just going to skip a bit on this side because I want to show you here that 71% of the patients showed a lack of effectiveness throughout the duration of therapy. So the patients who failed, which only 7 of them, so we talk about 7 of the whole group, when they failed, they were having a failure, most of them from the beginning. They didn't respond to the treatment, while about 30% showed an initial response and then that failed. So if they're going to fail, most of them are right at the beginning showing no response, but a small group of patients may still benefit initially, and then that can drop and the failure will happen. But again, the number is very small. So what we can say here that we have in the UK, the largest cohort at the level of NHS is certainly at Moorfields. We have the largest service in the country. We did not find any really serious adverse events that the patients needed to be treated in hospital for them. And our findings indicate that idiopathic patients may have a higher rate of failure, while the birdshot patients have a lower rate. But clearly, in clinical trials, when you look at what we do, we lump the patients together under a global term of a non-infectious posterior uveitis. Then you recruit patients into the study, and the patients will become a mixture of all the diseases. When you try to identify subgroups, it's not always easy because the numbers tend to be small, and you can't really draw very significant conclusions from those small numbers. But it is our impression that the birdshot patients tend to respond quite well. And the failures we found were more connected to the idiopathic cases. So these are observations that, of course, the more data we get, the more we'll be able to show if this is really true. And this is going to take some time for us to be able to achieve. I want to make one comment here. You are all aware, of course, of the existence of biosimilar drugs. And of course, biosimilar drugs have become an option because of costs and have been adopted by many centers. I'll share with you just an information related to our own experience with them. And I can tell you that many of our patients who have been giving a biosimilar are having difficulties adjusting to this treatment, and they are mostly asking us to go back to Humira. So there are many reasons for that, and one of them is the fact that a lot of these medications cause a problem with pain when they are injected, and other patients are experiencing side effects which they did not have during the treatment with Humira. So it's something that we have to be attentive, because biosimilars are coming in, and we need to make sure that these drugs are actually delivering what you expect, and the patient satisfaction is maintained. Just this is an observation of our experience, which is not in my slide. I just want to show you this case here, which is one case only, but illustrates very well the point that I was making before, and many of the things that Pier Giorgio also was talking about. So this is a patient with birdshot who was diagnosed in 2011. She was HLA 29. As per that publication, we only consider them birdshot if they are positive. And she was attempted treatment with different approaches, including steroids, tacrolimus, but this patient was struggling with his medications, also with mycophenolate. And she actually had reasonable good vision, which is a fact in birdshot. Many patients maintain good central vision, but the retina in general may not be doing very well. So this lady ended up having, in some situations, a local therapy. The most important complaint she had was some haziness of vision, some floaters, and we analyzed her, and we see that she didn't really have a very significant leakage here, but just very localized, a bit of vitreous involvement. But there was some inflammation going on. This is the fluorescein, and now the ICG angiography, and the ICG showed that she had a few of the typical lesions associated with the diagnosis of birdshot. You can see them here more easily. Just move my slide. This is her OCT, which shows that she actually had no macular edema. So from the point of view of vision, she was performing very well, but she was a very unhappy lady. So we had the electrodiagnostics carried out. It showed that she had some degree of dysfunction of the macula. She was complaining of the floaters. She was on a low level of oral steroids because she couldn't really tolerate higher levels. But there was a lot of unhappiness about the way things were going for her at that time. This is again what the situation was. This is in March 2016, and I'll show you here. Pay attention to this area, which is just around the optic disc, a little change that will happen over time. It is really relevant to what I'm going to tell you. Let me just move this slide forward. Again, we can see that she had no macular edema, and again, the appearance of a very little leakage in her eye, but clearly the presence of the choroidal lesions was quite obvious and more pronounced than in the previous assessment. So in both of her eyes, a very similar picture. Okay, so she was booked at this stage because of all the problems she was having with all the medications and the fact that she was still very unhappy. We decided to give her a trial of Iluvien, which is the fluocinolone acetonide implant I mentioned to you before. And that was given to both of her eyes. So she ended up having the Iluvien in both eyes. She had the electrodiagnostics to look at how the situation was behaving, and there was improvement of the picture of behavior of her retinal function. She was happier with the fact that she did not see the floaters as she used to see. So in general, she was extremely satisfied with the outcome of this Iluvien intervention that she was given. And this is again a test carried out. This is post-Iluvien, which shows here that she was having virtually no leakage, a few RPE changes. Again, the same situation in the other eye. But clearly here, look at her ICG was showing a very active presence of the dark spots in the choroid, indicating that the choroidal lesions were unchanged in spite of the benefit that the Iluvien was giving to her retina. So she was struggling with her systemic treatment. So we couldn't really use anything. And my concern was that she was still having an active disease without really control of her choroidal disease. You can see clearly here on this EDI OCT, the thickness of the choroid is increased. And this is already well into her Iluvien treatment, so the choroid is significantly thickened. And my concern also was that the peripapillary area in her eyes was showing progressive changes of the RPE. So that is the real point about choroidal pathology. Choroidal disease may be very silent, by far, because it's under the retina and the patients may not be able to see very much or at all what's happening in there. But what happens is over time, you are progressively causing damage to the outer retina, and that leads to dysfunction of the retina, which in the long term will lead to significant visual loss. So we have to be very careful with this aspect of these diseases because they may look benign, but in reality, they are causing a lot of trouble. So look at this, how much of that peripapillary area has suffered RPE changes, and there is this change in you can see here the window defect that is shown in the fluorescein angiography, and it's affecting both of her eyes. So she was then moved to adalimumab. That happened in 2019, and we can see that progressively following the adalimumab, the choroidal thickness went into reduction, and she improved that situation. And this is May. Look at what happened to her ICG angiography. So with the adalimumab on board, not only we could see the evidence from the EDI OCT, but there is clear evidence that the dark spots in the choroid have disappeared and been well controlled. So that happened to both of her eyes, in starting with the spots and then ending up with full control. So the message in this patient is that you have a disease which may be symptomatically not causing a lot of issues to the patient because of the location of the problem immediately, but in the long run, if left unchecked, it will progressively damage the outer retina and will result in a reduction of vision. So this patient suffered some loss. It took a bit of while for us to find the best alternative for her systemic treatment, which was needed to control the choroid. The other options were not tolerated, and adalimumab became the real way of controlling her problem. So this is a great example where you may find that local therapy has no role or limited role. In some situations, combining therapy is a good way of treating patients. So the use of the local therapy combined with the systemic therapy may be very useful for these patients. And I think in this case here, it's a good example where the local therapy benefited the retina, did not benefit the choroid, and the use of the systemic treatment in the form of adalimumab was the way of solving and controlling her problem. I think I probably have finished my slides here, and thank you, Noura, thank you, Pier Giorgio, and I think we're on for the questions.
Yes, thank you so much, Professor Carlos. There are a couple of questions. We'll start with Ahmed. There's an interesting question: how to differentiate macular edema in patients with vascular occlusive vasculitis in Behçet as related to inflammatory process or related to the occlusive process in the disease. His question, because of the aim is to know the cause, so should he inject anti-VEGF or increase his systemic therapy?
Pier Giorgio, do you want to go with that one? Because you talked about this in your presentation, your case, or I'm happy to tackle that if you want.
Well, I mean, I can give my view, and then we can combine the two. I mean, very briefly, let's say that it's when you see a patient and you have the specs for Behçet disease, particularly. I mean, number one, you have to tackle the problem with a systemic treatment. And I can tell you that I had a couple of patients that were treated with intravitreal anti-VEGF drugs. They were very effective since you are just happy the blood-retinal barrier. So I don't mind. I would prefer to go personally, with intravitreal anti-VEGF because, I need just to rescue the retina. And I believe that, this might be a sudden effect. But of course, I have to tackle the problem with systemic treatment. Somehow, depending on the severity of that and the basis of the grading I can see at the beginning of the disease, at the onset of the disease, I can even choose to go for intravitreal ones. Steroids, I mean.
Yeah, I think the important point when you're dealing with an inflammatory disease, I think it is that you want to be absolutely sure that you have brought the inflammatory process under control. So your question regarding should we treat with that, because what's happening here is it's a combined process. You have inflammation leading to occlusion, and it may be a combined mechanism which is generating the edema. So first step is control inflammation well. Bring that under control, because if your inflammation is under control and your edema is related to the inflammatory process, that will automatically respond. But you may very well control your inflammation, but because there's so much ischemia, you end up with still the stimulation for the edema to continue. Then in which case you have to to look at your options, and the options would be using your anti-VEGF as a way of shutting that down. But ultimately, what Pier Giorgio showed in his presentation is that if you have significant ischemia, you end up having to laser ablate that area to stop the VEGF stimulation and stop this process from getting worse.
Okay. The next question from our colleague, Dr. Ahmed Al-Janabi. Is there any variation in response to anti-TNF-alpha in case of posterior non-infectious uveitis? For example, Behçet versus non-Behçet uveitis as birdshot, for example, and why is that?
Carlos, you go first. I think that this question can be tackled by you.
Yeah. Okay. So I think what we observe is that there isn't one medication which is good for all types of uveitis. And you just remember what I said in the trial situation when we recruit this lump of patients and we find a response, which in case of the visual trials was very positive in showing the benefit. When you try to break down, you may find that it's not all diseases will be responding equally to that. So I think the experience that I just showed you from our Moorfields data, limited data in a short period of time, is that our idiopathic patients, for instance, did not respond as well as the patients with birdshot. So Behçet's disease is a great example of the patients who benefit from this. We know from the infliximab studies initially, and then adalimumab, this is a great group of patients who respond. It's not necessarily clear why the mechanisms are that explain the differences between them. Pier Giorgio is the immunologist, is the person who knows more about how all these cells work and how these communications are going on. But I believe that in most of the times we are not absolutely certain why the differences are occurring. If you're targeting a specific element of the immune response, which plays a major role in one disease, that will be the explanation why in that disease you see good response. But I think, Pier Giorgio, would you like to comment on this specific aspect of the response?
Yeah, I mean, it's a matter of fact that we can have several different immune genotypes, which are then, matching what immunophenotypes can be. Let's say that even in the registration trial for adalimumab, we saw an heterogeneous, population of people that was treated by adalimumab just because, it's impossible to run a trial with only one disease. And I can tell you that there's one thing which is reassuring about the efficacy of the drug, of anti-TNF-alpha at least. It seems to be very, very useful for retinal vasculitis. I mean, Behçet disease is the worst one. When you have to deal with Behçet disease, you saw even for the registration trial for anti-interleukin 17 and anti-interleukin beta-1 receptor, you saw that there was a big failure, in terms of efficacy of these drugs. So let's say that I've never saw someone, with a sudden and permanent vision loss, belonging to the multifocal choroiditis family, even though you may have, an outbreak of Volcker-Yanagi-Rada disease, for instance, but, vasculitis is the real problem. So let's say that I'm reassured that I have enough, something that can tackle the vasculitis with a certain efficacy. But I agree, that, the interplay between the cells can create different scenario, and not everyone can be tackled very well by anti-TNF-alpha agents. But so far, one thing which is just reducing the stress is that at least we can tackle the worst one, and then we can have enough time just to go through the problem. And if it is not sufficient to use an anti-TNF-alpha agent, we can go further and use other agents. But of course, they are off-label. That's the major concern that I have.
Yeah, I think the point to make is that there isn't a very well-established, tailored relation between one drug and a disease. Okay, this disease can only be treated by that. That doesn't exist yet. It's possible that in due course you're going to have off-the-shelf your Behçet's treatment, your VKH treatment. That is, the more the knowledge progresses in terms of understanding the immunology of these diseases, and we find treatments that will interfere with those specific elements of that response, you may find a situation when you get close to that. But remember, the variation amongst the population of individuals with the same disease may still be wide enough to make that you won't be able to achieve one drug for all. Okay?
Yeah, true. Absolutely. I agree 100%.
Okay. The question from Khalid to Professor Neri. from your vast experience with biologics and the management of uveitis, what exactly the checklist we should do prior initiating the anti-TNF or adalimumab?
Well, actually, I would say that, that is pretty clear, particularly here in a system where we have to deal with assurances. And, as per the assurance, the checklist is just very, very easy. OCT first, just to prove that you got something, in the retina, because otherwise you're going to have troubles in getting the approval. You need to rule out every single hepatic problem, means all the possible hepatitis A, B, and C. And of course, you need to check, them. And tuberculosis is absolutely important, because this is not only for the regulation that might be done by the assurances, but there's a publication that came up, I think 15 years ago, I can't recall exactly, that was reported in Thorax, that if you use an anti-TNF alpha agents, whatever it is, you can have the sudden death of the patient for a fulminant tuberculosis. So number one, rule out tuberculosis, so just exclude it, and that's the most important thing. But I would stress also other aspects, which are just the standard workup that you have to do for every single patient, like a CBC, renal function, and liver function. So these are the ones that you have to go through in order to get the approval. And after that, you can go for the prescription right away.
Yeah, I think just to add to that, Pier Giorgio, what we do as a routine is MRI scans for patients with diseases that could be associated with a demyelination. This is something that if we have an...
Well, depending on the type of the disease, let's say that, every single country is different. But I mean, if I see an intermediate uveitis, even though I don't have that large cohort of patients with intermediate uveitis that has to be treated with adalimumab, I would say, I have a prevalence of posterior uveitis, which is much worse, or maybe panuveitis. But if I see an intermediate uveitis, I can tell you that I'm slightly reluctant. But when I have to treat that, I go for the MRI right away.
Yeah.
But just from that case, not with the others.
Sure. Agree.
Yeah. I think this is our last question, the upcoming question, and as we'd like to have a brief idea about each of the speakers. I know that we have touched a little on it, and we mentioned it. What is your experience with VKH patient with adalimumab?
Well, VKH is a primary choroidal pathology, so it becomes a panuveitis, of course, but in terms of the back of the eye is a choroidal disease. So clearly, the options of local therapy that I discussed with you before have no role here. They're not going to control this patient well at all. So these are patients who need systemic therapy. Most VKH patients tend to respond, at least initially, very well to high-dose steroids. And these patients today go straight into a second-line therapy because we know that they need very tight control. It's very important, that window that our friend and Professor Herbort published. We published that with him, showing that the window of opportunity to control VKH is in the early stages. So you really need to act quickly and aggressively to bring it under control and prevent long-term damage. I think by far the patients tend to respond to this approach. We have used VKH, adalimumab, to treat with VKH in situations where we are finding that the control has probably failed right at the beginning. We get patients already in the course of disease, which is not really responding very well, which may be that window was missed, and these patients are suffering more recurrences or more difficulty in controlling their disease. So these patients are the ones that we tend to go for adalimumab, and we have seen that many of them, that difficulty in controlling is improved. It doesn't mean that all patients will respond to that approach, but I think it is a good alternative in these situations. Pier Giorgio, you can add your views.
Yeah, well, actually, I can tell you, I don't know who's the one that asked this question, but I want to thank, this colleague for a reason. Since this is going to allow me to have a spoiler of what I'm gonna, collect and publish, because, Carlos, here in UAE, we have an endemic disease, which is diabetes. Mm-hmm. So very often I'm really forced, to do the best to control the diabetes. So sometimes when you have young patients with VKH, and this occurred, which are type 1 diabetes, affected by very bad diabetes, no diabetic retinopathy, but weak AH, and we collected 7 cases. We treated the patients without steroids, and I can tell you that the result was amazing. I mean, you saw the thickness of the cord that went down, but the most amazing thing was that diabetes got better. And we don't know how. So we're going to collect the data, and I hope to come up with the publication as soon as possible.
Yeah, I think this point highlights, Pier Giorgio, one of the things I said in one of my slides. You have to look at the patient as a whole. So if there is a reason why a certain intervention is likely to be detrimental to that patient, then looking for alternatives is absolutely what we need to do. So finding options that can be effective, avoiding the ones that would potentially be effective but causing harm is really a very good step. So I'm happy and glad to hear what you're doing and you're going to publish, because clearly the experience in different countries will be different. So and this experience shared with the others will help us eventually in similar situations. Even if we see less of that, when we're confronted with them, we are going to be in a better position to offer the treatment for the patients.
I want to just leave a very brief comments. It's just the fact that I'm very close to what the rheumatologists are doing nowadays. Since, you know, rheumatologists are starting with just to put under controlled immune system much earlier the treatment with biologics rather than they did earlier, you know, long time ago. Yep. So I would say that when you see something which is very severe, sight-threatening, and it can affect the patient in the long term, I think that it's better to think about that the first-line treatment with the anti-TNF-alpha agents and adalimumab instead of trying to keep on other medication. So this should revert the concept, and we can think about that.
Yeah, no, this is a very important point. Whenever we're starting with a new drug, especially if they're expensive and the experience is not there, we tend to use them as a situation where you've tried everything else and then you go for that new drug. And that usually means the results may be not as good because you have selected a bad group of patients to be treated. With the experience that you build, you start moving that new drug up your ladder. So you start to use this earlier than not using at the moment. And that will show the real benefit of stopping inflammation very quickly, very early, and preventing this bad progression. So that's a very well taken point there, Pier Giorgio. Thank you.
Thank you very much, guys. I mean, I do really appreciate it. Thank you.
Thank you very much.
Seems that we are ending the webinar just on time, 3 minutes past the estimated time. Really, I thank you so much, Professor Carlos Profizio and Professor Noura Pier Giorgio, regarding to host you, both of you. It was a refreshment course to me, and I'm sure that all the attendees have benefit a lot from you, both of you. I extend my thank to AbbVie Immunology and Mrs. Rima for her tremendous support to us and her extended to her. I'm thanking them also to all her team. Looking forward for further collaboration with you both.
Thank you very much, Noura, and thank you, Pier Giorgio. Thank you all.
Stay safe and hope to see you. Bye-bye.
Okay. Bye now. Thank you. Bye.
Bye.